So our focus in Amsterdam is the delivery of stereotactic ablative radiotherapy in high-risk patients, and in particular we're looking at outcomes of a novel approach, which is MRI-guided stereotactic radiotherapy. Now today we were happy to present the early clinical outcomes for 50 patients that were treated consecutively since we introduced this novel approach in Amsterdam in early 2016. So we're really trying to see who will benefit from a very novel approach which introduces MR imaging into the radiation oncology workflow, meaning we can adapt our treatment plans on a patient's anatomy on a daily basis. So we are more precise in our treatment delivery, and we can also visualize a tumor during treatment delivery continuously, which helps us to reduce our target volumes. So essentially, since we introduced MR-guided stereotactic radiotherapy in Amsterdam, we have used it selectively for high-risk patients. Lung cancer is maybe not the first indication you think about when you think of MR imaging, because CT imaging is still the gold standard there. However, we have found that it can be of an advantage to use MR guidance in selected high-risk cases in whom we believe there is a narrow therapeutic window, such as centrally located lung tumors or also patients with coexisting interstitial lung disease. So we slowly started to select patients for this approach, and we quickly learned that it works very well if we adequately select patients. And we observed also that we can achieve now good control rates and also low toxicity in a high-risk cohort. So we successfully started applying this and built experience in a very novel approach here. So the main results in the first 50 patients or 54 lung tumors that we have treated is that we can achieve good early tumor control rates, which are above 95% at 12 months. And actually all the recurrences that we did observe were in cases that had an inherent risk of recurrence, such as re-irradiation cases or colorectal cancer metastasis. So that is very encouraging. Of course, we also have to consider the follow-up is still quite short with a median of 18 months. However, we believe it is very important to look very critically at these early outcomes, because there are always risks involved in the introduction of novel technologies, which is why we have to be careful when we just use a novel technology in these patients. Also, at the same time, we saw that the toxicity rate was very low in our cohort, which is encouraging in a high-risk cohort of lung tumor patients. So the next step will be to define exactly which patients will benefit from this approach, which is quite resource and labor intensive. So our main conclusion is that MR-guided SABR can achieve a good early local tumor control rate as well as a low toxicity rate in patients with high-risk lung tumors. This is of course very encouraging, but at the same time we need to be very aware that this is a resource and labor-intensive approach. Not every patient with lung tumors will need this approach, so we will need to precisely define the benefits and adequately select the patients who may benefit from MR-guided SABR. So those are really the next step that we'll have to take in the future.